Hello, everyone. Thank you for joining us for today's webinar. WCA Hospital shares their EPCS success story. I'm Michelle Lero with Imprivata, and I'll be the moderator for today's session. Joining me today, we have Laura Josephson, RN and Clinical Informatics Manager and EPCS Project Lead at WCA Hospital in Jamestown, New York. Laura is going to be sharing the strategies and technologies that WCA Hospital used to become one of the first healthcare organizations in New York to successfully implement EPCS. Welcome, Laura. Also joining me today is Dan Borgasano. Dan is our Product Marketing Manager here at Imprivata, and I am going to hand it over to Dan in just 1 minute, but first we'll cover a couple of quick housekeeping items. First of all, today's webinar is being recorded, so if you'd like to share this information with a colleague, you'll be receiving a link in the next 1 to 2 business days, so look for that in your email inbox, and you can go ahead and just forward that link on, and that's an on-demand version of today's session. Second, if you're having any trouble with the audio or video portion of today's webinar, usually hitting the refresh button on your browser will take care of it, but if that doesn't work, you may have to log out and log back in again. And then if you just can't resolve that issue, again, you will get a copy of the recording so you can watch the on-demand version. Finally, we're going to have a Q&A session at the end of today's presentation. So please go ahead, feel free, enter your questions at any time. On the right-hand side of the screen, there's a box labeled Q&A. You want to go ahead and enter your questions. You don't need to wait until the end. You can enter them during the webinar, and then at the conclusion of the presentation portion, we're going to go ahead and take those questions. So that is enough from me, and I'm going to go ahead and turn it over to Dan.
Great. Thank you, Michelle, and hello, everyone, and thanks again for joining today. So let's quickly review the agenda for an overview of what we'll cover. I'll start by introducing our guest speaker in a little more detail. Then we'll review some of the benefits of EPCS and drivers of adoption. We'll then hear directly from WCA Hospital about its EPCS project and some of the great results they've achieved. And then we'll close with an overview of Imprivata Confirm ID before opening up to your questions. So joining us today is Laura Josephson. As Michelle pointed out, she's a registered nurse and clinical informatics manager at WCA Hospital in Jamestown, New York. Laura has 15 years of experience leading the implementation of clinical technology and systems. Currently, she's optimizing clinical applications and workflows at WCA Hospital and is a project lead for their successful rollout and adoption of EPCS. Laura, welcome again. So before I turn it over to Laura to hear about WCA's successful EPCS project, I want to provide more context as to why EPCS matters and some of the drivers to adoption. So from a societal perspective, the abuse of prescription medication is a national public health crisis. It contributes to more than 23,000 deaths annually, and as you can see from this chart, that's more than cocaine and heroin combined. EPCS can play a role in combating America's prescription drug abuse epidemic by addressing doctor shopping for pills and reducing drug diversion and fraud. But beyond the societal benefits of EPCS, there are a number of other benefits and drivers to adoption. The first is the inefficiencies caused by dual prescribing workflows, electronic for non-controlled substances and then paper-based for controlled substances. This is frustrating to providers and leads to dissatisfaction. And it also creates patient dissatisfaction by forcing them to deal with 2 different types of prescriptions. With EPCS in place, the dual workflows are eliminated. Prescribers have a simplified, consistent workflow for all prescriptions, which improves productivity and enhances patient satisfaction by minimizing wait times at pharmacies and reducing unnecessary doctor's office visits. So what's more, the number of prescriptions for controlled substances is increasing, and this is being driven largely by the reclassification of hydrocodone combination products such as Vicodin to Schedule II controlled substances. As many of you know, these are among the most prescribed medications in the U.S., and the reclassification puts tighter controls on how and how often they can be prescribed. For example, no refills are allowed, and prescriptions cannot be called or faxed into the pharmacy. So this means that the number of original prescriptions written for these medications will increase substantially, which really exacerbates the challenges associated with dual prescribing workflows. In fact, we have a customer in California that accelerated its EPCS implementation when the reclassification was announced because the CMIO knew what a significant impact it would have on his clinical staff. So another driver for EPCS is what's happening in New York, where the state's groundbreaking iStop law mandates electronic prescribing for all medication, including controlled substances. This has really compelled EMR and other technology vendors to certify their systems to meet DEA requirements for EPCS, and it has also driven pharmacy readiness nationally, and today about 75% of pharmacies are EPCS ready. So even though many of you may not be bound by iStop requirements, it has really been a compelling factor to get a lot of the basic infrastructure in place to meet the DEA requirements. And then finally, another driver for EPCS is to really limit exposure of a physician's DEA number. Our studies show that about 1 in 10 doctors admit to having their DEA number stolen. EPCS can address this because the DEA number will never be in the patient's hands, and that should reduce the risk of fraud, drug diversion, and theft, all of which contribute to America's prescription drug abuse epidemic that I discussed earlier. So with that, I'll now turn it over to Laura Josephson to discuss EPCS at WCA Hospital and how she has driven a successful implementation. Laura?
Thank you, Dan. It's great to be here today. What I'd like to be able to do is just kind of share our story with you as far as who we are and what we did and how we did it. Generally, WCA is a hospital. It's a hospital.
Laura, are you there? Laura, are you there?
Hello?
Apologize for that. I think you're back on the line. There was some sort of technical glitch on the WebEx, but please go ahead. And I'll advance your slides for you. There seems to be an issue with the slides advancing, so I'll go ahead and do those for you.
Okay. Again, I just wanted to say thank you for having me here today, and I am actually looking forward to sharing our story with you and with the audience as far as how we were able to roll this out in Jamestown, New York. This is going to be a story of a facility rolling out EPCS as opposed to a provider practice, but I think you'll find that there's a lot of key points and items that are really going to be the same regardless of what type of setting that you're coming from. WCA is a community-based hospital. We're located in southwestern New York, kind of south of Buffalo, if people are familiar where that is. And it's a hospital that has all the kind of general services you'd expect at a community hospital. You know, there's primarily med-surg, there's OB/GYN, you know, mom and baby services. There's also, we have psychiatric services, so that we have in and outpatient services for mental health and for chemical dependency, and all the associated outpatient services that you might expect to see as far as sports medicine, physical therapy, OT, et cetera. And what we did is we rolled out our EPCS to everybody all at once. We have 132 physicians that are actually on our active practicing staff. Not all of them are actually candidates for the EPCS because of the specialties that they work in. And so I think some of that is sort of self-explanatory, but just like the pathologist, we're not going to enroll. They're not going to be prescribing at all. When we looked to do the EPCS rollout, it actually started probably about a year ago where we just started educating ourselves, and we started looking at all the articles that were coming out about the epidemic in the country with prescriptions and narcotic abuse and prescription forgery, et cetera. Started looking at the laws that were coming out in New York State, and just began kind of thinking this is something that we really need to do. Our software vendor was getting ready to get their product certified, and just started looking at all the patient safety factors. You know, like I said, for us, the iStop was probably really the driver for this as far as the timing of when we did it. But it was, when we thought of patient safety, you know, this is, to us, a great thing. We're going directly from the physician to the pharmacist. There's no middleman, there's no interpreting of the handwriting, there's no interpreting of the voice that can sometimes be hard to distinguish or to be clear on or whatever. The other thing that I think that, and Dan kind of alluded to this, there's no dual workflows now. We had at our facility, the majority of our physicians were e-prescribing or e-printing out of our software. So we have, through our reconciliation discharge workflow, they have the ability to print prescriptions. That was happening, but I think as everybody knows, printers run out of paper in the middle of things, printers jam in the middle of things, and because they were maybe e-prescribing some of their prescriptions, but then not having the ability to do so, they were using two different workflows. So we really were able to increase, I think, provider satisfaction as well as patient safety, because they could now just print or e-prescribe everything and not have to stop and wait for the printer to print, but send some things. So it just became much more efficient for them. The other thing that I think was really important, too, is to make things clear to our patients as far as what was going on. So as part of their discharge instructions, we put an icon on there with a legend that would tell them this prescription was sent to this pharmacy, or this prescription was printed, or this was sent to your mail order pharmacy, so that the patients, as they were being discharged from the hospital, could have a clear idea of, and even the nurse reviewing those instructions would know what happened with that prescription. So it made it more, I think, efficient and clear to the patients, too, when we put some of those extra things in place. The other thing that I'll just sort of mention here, since I'm talking about the nursing staff, is one of the things that became very important for us was that our nursing staff was educated and on board with this project. The nursing staff is responsible for entering and collecting the patient's home medication list, and as part of that, they also collect and or verify the patient's pharmacy. If that pharmacy isn't in there when the physicians go to do their e-prescribing, it makes them hesitate and maybe hit the print button instead, as opposed to, stopping and taking the time to question the patient and enter that themselves, although they can do that if they so choose to. The team that we pulled together consisted of a variety of different people. For us, our informatics team was actually the lead on this project, and it made a lot of sense to us to have our informatics team here lead the project, because we're the group of people that the physicians were used to working with when we were rolling out new technology. It was the group of people that the physicians had come to trust when there was technology involved. So because we were going to be asking them to utilize new technologies, they became the natural lead and go-to people for this project. But because of all the technology involved, we also had on board our network team, who did a lot as far as actually setting up and getting the Imprivata pieces to work, getting the hardware deployed for our fingerprint readers, et cetera. And those were real important things, particularly early on as we were leading up to the rollout. We used our medical staff services. Our medical staff credentialing office had a good idea. I mean, they keep a lot of records already, so we actually won't provision or enroll anybody that hasn't been through the credentialing process. So that's almost like a first step here. We got a lot of policy input from our credentialing office. We used our medical staff services, too, to start talking about e-prescribing early on, actually months and months before, to start bringing it up at department meetings that this was coming, that New York State was looking at this, that our hospital would be looking at this and rolling it out soon. We also used a lot of, I guess what I would call provider super users, people that we go to for their thoughts, physicians that we maybe work a little closer with to get some of their input on how does a physician think, how does a physician work, you know, what is the workflow for this particular component of what they do. Our administration staff was on board, and we needed them too as far as getting everything communicated and just the oversight to the policy that was being written, since it did cross departments. We used our vendor consultants, and I encourage you to take advantage of some of the knowledge that they have. I think because they've had to go through the process of getting their software and their appliances and applications certified by the DEA, they have a wealth of knowledge as far as what's involved in that process. And I included on my team the New York State Bureau of Narcotics Enforcement. I don't think they knew they were on my team. However, we did call them. We listened to webinars that they presented. They were incredibly helpful. You really get the feeling that they wanted you to succeed in this effort and to succeed by doing it, you know, the right way. This slide here just sort of represents some of the different vendors that we actually worked with. You have to have a certified product, and the software that you're doing this through needs to be certified by the DEA or following their process. There are some other folks that can do it for the DEA. We use at WCA, it used to be Siemens Sorian, and now it's Cerner Sorian software. So that was probably our biggest thing that was foremost. But Sorian had also partnered with Imprivata as their go-to provider for two-factor authentication. We were elated to hear that news because we already were using Imprivata for a couple of our other solutions. In fact, we've been a long-term customer of Imprivata. We rolled out their single sign-on solution before we went live on Sorian, so that our providers were used to doing that. We also were using their remote access solution so that our physicians and our IT staff that wanted to access the hospital network could do so securely from any device, essentially, where they were working. When it came to selecting the two-factor authentication, we reviewed some different things, and again, this is an area that we talked to a lot of our physicians to kind of find out what workflow was going to work well for them. And fingerprint biometrics kind of made sense to us. It was actually something that we've used here before, and it's something that is incredibly efficient if you have your fingerprint devices in the places where they're needed. So that sort of makes sense. But we also, in talking to them, needed to have a solution. So what if they were at a computer in the hospital that didn't have a fingerprint reader? What if they wanted to do something from their home or office? And that's where we decided to use soft tokens. And we do use semantic VIP access for our soft token provider. And that has also gone very well. And this is, for us, what we did is we rolled this out on their, you can do it different ways. You can put it on the PCs or whatever, but we chose to only make it available through a secure smartphone. So if they have a smartphone, they can download the app on their phone. We enroll them in the product, and you just kind of get that rolling, secure, one-time access password. The other provider that I guess that I would say that we worked with is SureScripts, and SureScripts, again, because we've been e-prescribing for a while, we were already familiar with syncing our physicians up with SureScripts and utilizing them. And we also used SureScripts to do an import of our home med list. So that's something that's gone pretty well for us. When it came to the actual rollout of the product, in the identity proofing and the enrollment, one thing that our team did first is we became very familiar with the process ourselves. We wanted to know how this was going to work, what were we going to be asking the people to do. So we have our own physicians that we created in our test system, and we enrolled our own fingerprints, and we downloaded the soft tokens, and we actually, with test patients and test user logins, went through the workflow many times ourselves, just practicing and making sure that we knew it well, so that we were real comfortable as we were bringing in the physicians and getting them signed up and enrolled. We wanted to make it look easy to them, and I think knowing the workflow well, even though when you look behind the scenes, the incredibly complex and elaborate, complex process, on the front end, we wanted it to look safe, we wanted it to look easy, and it really helped us to be able to do that. We decided also that we would do our identity proofing and our enrollment and even our education, I'm going to tack that on too, all in one session. So we set up some open enrollment sessions and kind of used those as a way to get people to stop in. We put them at convenient times around lunchtime or late evenings or early mornings when physicians were kind of coming and going in the hospital, where you tended to just have a few extra minutes. We let them notify us ahead of time if they were going to stop into an open enrollment, because there was actually some of the work that we could do ahead of time. I had said that as part of our identity proofing and getting them ready to enroll, we knew they had gone through our credentialing office, but we wanted to make sure that that medical license was up to date and current, and we wanted to make sure that that DEA registration was up to date and current. So we logged in and actually verified that, and if they called us ahead of time, we would do that, the day ahead of time or whatever. When they showed up for their enrollment, they had to bring a government-issued photo ID. Majority of people brought their driver's license. A few people brought passports. And so we recorded all the information, and we have files or logs, whatever you want to call them, on this for each physician that we're enrolling. We would then enter them into the Imprivata product or the SureScripts product if they chose to have the soft token. Not all of our providers wanted to have the soft token, but it was available there for them. So as they moved out of the identity proofing segment of the enrollment, we had other staff that was from our informatics team that would actually enroll their fingerprint and get them set up with the token if they were going to be using it. We then had education available. The education would either be provided in the form of, if you wanted to sit down and go through it, we'd sit down and we'd go through it with you so you could actually see how it could work. Our providers that were already e-prescribing, which we had been encouraging people to do for the last several months prior to the rollout, they just needed to know, well, what's going to be different? What steps do I take when I'm doing a controlled substance? So for them, that was a little easier. We had handouts available. There were some screenshots that kind of showed what they would see. So if they didn't want to stay and do the education there or go through the process, or even if they did, they would still have that handout to take with them so they could review and have it available. And I think that was very helpful. And there's always, of course, that open concept of if you're doing it and you need help, call us. We'll either come meet you or talk you through it or set up another session with you, et cetera, whatever they needed. Another thing that we were able to do to increase the efficiency of the EPCS registration, in New York State, each provider has to register each software that they're using with the New York State Department of Health. Some of our providers had already done this at their offices with the software that they were using there, but they also had to do it with the software that they'd be using through the hospital. One thing that we had found is that they were using, paper forms or submitting online, but everybody was doing it individually. New York State, shortly before the proposed original mandate of March 27th, 2015, made available a facility registration where we as a facility could create a file and send it in, and everybody could get all their software, or we could enroll all of our providers at once with the state. It was a simple file to create. Every time that we add new providers to our list of who's enabled for e-prescribing, we would simply just add their names and their information. Actually, you don't add their names, you add their DEA to that file, and then you re-upload the entire file with the state. And that actually really streamlined, I think, things quite a bit, because that became available kind of at the 12th hour, but we were really excited to have it and to just sort of speed up that part of it. We talked a little bit, again, about understanding the workflows, and this kind of comes from talking just to different physician practice type groups. This helped us a lot with where to place our fingerprint readers. We found out that, you know, when you look at your surgeons, they typically are walking around in scrubs. They don't always have a cell phone with them, but they're putting in a lot of orders, especially for outpatients that are going to be discharged while they're sitting in the PACU or the OR lounge. So we made sure we had fingerprint readers at those computers. We walked up on the floors and actually talked to physicians and the charge nurses or clerks to find out where are the computers that the physicians generally tend to sit at. So we may have you know, 18 or 20 computers up on a unit between mobile devices and desktops, but what we did is try to identify at least maybe 5 or so on those bigger units that tend to be used by physicians, and to put fingerprint readers there. It was the other thing too with some of our providers didn't want soft tokens. They said, I'm never going to e-prescribe from my home. I don't want patients to know I can do that, so I only want to be able to do it when I'm here. And so it was just kind of understanding some of those thought processes. We put them in lounges. We actually found an area. We have a unit that doesn't currently have any patients housed on it, but it's still open. And there's an area on that unit where we found that physicians tended to congregate, and it was just quiet, and they would sit and do their work. We put fingerprint readers there so that they would be accessible to them. And again, the folks that did want the soft tokens, it was there for them. We chose not to go with hard tokens because this is what they had from some of their office practices. They found that they didn't like it. It was one more thing they had to keep track of or keep on their key ring, et cetera, and wasn't an option that we felt that we wanted to support, having all those devices out there. Oops, sorry. This slide here sort of represents a little bit just some of the numbers that we were seeing, and this is actually data from, we went live March 27th of 2015, or actually, I'm sorry, March 13th. Even though New York State did not, they did extend the mandate to 2016, we decided, since we were already underway, had all our devices deployed, had all of our open enrollment sessions planned, that we were just going to keep going with our date, and it would just become a soft rollout instead of a hard one, which I think was nice for a lot of different reasons. What the slide does show, though, is it's sort of representative of just after that month worth of data, which at that point in time, we only had about 34% of our providers live. That number has increased since then, but looking at this April data, we saw that, I mean, obviously our e-prescribing for controlled substances, this one says 28%. That's actually closer now to, it kind of fluctuates between 30 to 35% of our e-prescribed scripts are sent electronically. But we saw also a big uptake in just our e-prescribing. Our e-prescribing rates rose significantly. And I think some of it was just that we now had providers interested. We could provide one workflow for the process. The whole efficiency around it became so much more improved. And also going to point out here, too, that our meaningful use numbers for e-prescribing also rose, because when we look at our overall rate this is just our areas that count for our meaningful use reporting, we've hit a good uptick in that area too, so it's really helped in that regard. I'm going to just add on a couple of other things. Some of it I've already talked about, but one thing that we did before we did our rollout, starting a couple weeks before, we can tell from SureScripts in our software what pharmacies have e-prescribing software available, but it doesn't guarantee that they've turned it on. So we called the pharmacies in our vicinity in a radius and just talked to them and said, hey, you know, this is the hospital in town. We're the only hospital in town. We're going to start doing this. Are you ready? Some of them that didn't have the Shield said, gee, we called them anyways, and they said, we're not ready today, but we're very close. We're going to have it in the next 2 weeks. So that was kind of good information to gather, too, and it was just good to have that conversation, I think, with them, so that they knew we were getting ready to start up. And we actually found that probably just over 90% of the hospitals in our area were ready to start accepting controlled substances through e-prescribing. I talked again about, you know your audience, understand the workflows, understand the people that are going to be using this technology. Take the time to really understand the regulations, too. And again, we did a lot of reading on the New York State website as well as the DEA website, because it's the people that are educating on the software are the ones that are getting the questions about the legalities or how do I handle this or that. So that was really important. And then, again, just the education with the providers and the patient, or the providers. The patients, I think, were, that was just part of what we did with our discharge instructions and letting them know that, it's just so nice for the patient when they've had surgery. That script goes directly to the pharmacy. When they're on their way home, they can just stop and get it. They're not having to make 2 trips, or they're not having to wait for 20, 30, sometimes longer minutes at that pharmacy while that script's getting filled. So, again, just overall, just a very good thing for everybody. And Dan, I guess I'll turn it back over to you to wrap up.
Great, thank you very much, Laura. Appreciate that, walking us through the process and some of the great results that you've seen so far. So before we do open it up to some questions, I just want to walk quickly through Imprivata Confirm ID, which is our product that Laura and WCA use for EPCS. So this is a busy slide, but it really intends to show you sort of all the things that Imprivata Confirm ID can do and how it can help you meet a number of the DEA requirements for EPCS, while at the same time giving your providers a fast and convenient solution that integrates with their existing e-prescribing workflows. So Imprivata Confirm ID is really designed to create that secure chain of trust that the DEA is looking for, enabling provider identity proofing, supervised enrollment of their credentials, and enforcing 2-factor authentication requirements while maintaining a comprehensive audit trail throughout the entire process. So using Imprivata Confirm ID as a single integrated platform, you can complete the identity proofing process for providers, either using the institutional or as in the individual approach for providers doing it themselves. Imprivata Confirm ID also allows for the enrollment of a provider's credentials into the system, and that's sort of the enrollment that Laura had talked about that they went through. It'll either automatically be done through the credential servicing provider if you choose to do individual identity proofing, or through the supervised enrollment process if you go down the route of institutional identity proofing. We also support the broadest set of 2-factor authentication modalities for EPCS order signing, which I'll go through shortly, but really that gives your providers the flexibility to use the authentication methods that best meet their e-prescribing workflow preferences and requirements. Imprivata Confirm ID also integrates directly into the e-prescribing workflow, which again makes the process fast and convenient and seamless for your providers. And as I mentioned, Imprivata Confirm ID offers a comprehensive auditing and reporting functionality to keep the necessary records of the entire EPCS process and, again, help establish that secure chain of trust. So for providers, as I mentioned, Imprivata Confirm ID integrates directly with their e-prescribing workflow, It's called when the provider is prescribing a controlled substance. This means no extra clicking or navigating to a different system, which saves time and really keeps the provider focused on sort of the task at hand. It also supports multiple DEA-approved two-factor authentication modalities, which includes fingerprint biometrics, hard and soft tokens, as well as our new hands-free authentication solution. The EMR integration and the support for the multiple two-factor authentication modalities are really important because, again, they help EPCS fast and convenient for providers, which is really critical to adoption and then the subsequent success of your project. So I quickly just want to talk about two-factor authentication here. Again, we support some multiple different modalities and combinations of those modalities. At the time of prescribing, the provider is only prompted for what modalities are available and allowed. So really giving them this sort of must-have flexibility will drive adoption and satisfaction because, again, it'll make it fast and convenient for your providers. Hands-free authentication is sort of our newest modality, so I'm going to take a quick second to discuss that. So this is a breakthrough proximity-based solution that really offers exceptional speed, convenience, and security. It leverages Bluetooth connectivity to wirelessly retrieve and verify a one-time password from an Imprivata application that's running on a user's mobile device, even if the phone is locked and in their pocket, without requiring any manual interaction. And yes, it is approved for EPCS by the DEA. And also, if for whatever reason, the hands-free capability is not available at the time of prescribing, the Imprivata ID app can serve as sort of a traditional soft token. So again, it's sort of one application to give them that flexibility. And so then there's the benefits IT, of course. Imprivata Confirm ID can help you meet multiple requirements for EPCS in sort of a cost-effective and efficient, easy-to-manage way. It supports multiple EMR systems, so if your organization is using more than one EMR, you only need to deploy Imprivata Confirm ID once. And that's going to really give your providers a consistent experience when it comes to EPCS, no matter sort of where they're prescribing from in your organization. It's also, again, a single platform for the identity proofing and credential enrollment, as well as the auditing capabilities. So that's just a quick overview of Imprivata Confirm ID. Before I open it up to questions, I really like this quote that Laura had given us from one of the surgeons at WCA Hospital. And as you can see here, they said that e-prescribing for narcotics is easier and faster for prescribers and patients alike. It has better documentation and immediate pharmacy feedback, and is probably the best change to prescription writing that New York State has done. So really that speaks to the convenience and satisfaction and efficiency for both prescribers and patients when it comes to EPCS. So with that, we'll now open the line up for questions.
Thanks, Dan and Laura. So again, go ahead on the right-hand side of your screen. There's a panel labeled Q&A. That's where you want to put your questions in. We're going to try to get to everyone's questions. We do have quite a few people. I'm going to address one question. Somebody asked if they're the only person on this webinar. You are not. You've got quite a few other people on the webinar with you today. The attendees can only see the speakers. They don't see the other attendees who are on the line, just to, for privacy purposes. But we do have quite a few people on the line. We're going to try to get to your questions, so go ahead and get those in. I know Dan, I think, is going to kick it off. He's got a question ready for Laura here.
Yeah, so we've got several questions coming in. Thank you, everyone, and thanks for keeping them coming. So, Laura, one question here about the identity proofing process that you discussed. One of our listeners would like to know that for identity proofing your providers, wasn't it satisfactory to simply have your credential office internally verify the identity of your providers? Why did you need to go sort of that extra step? And I think that's, sort of part of the regulation requirements. You need to submit and verify their identification with the appropriate regulatory boards, correct?
That's right, Dan. And I think that is an option you can look at. You can have the credentialing office do the identity proofing. We wanted to do it timely, so it was right as we were getting people registered and enrolled in the software. And I think the other thing, too, is it made sense for us to, because our credentialing office, once a year they're credentialing people, we wanted to make sure at that time that everything was up to date and that we weren't submitting anything that had changed since they had last been credentialed.
Great. So we have another question here about sort of, when you were talking about the vendor collaboration, people wondering if you can talk just a little bit more about how you directly worked with the Board of Narcotics Enforcement and then SureScripts. Did you sort of work directly with them? Did you have a contact? Was it more on the clinical side? And what kind of was the most value you got kind of out of both of those entities?
Sure. As far as the Narcotics Bureau of New York State, we had attended webinars that they offered or that they were panelists on, but they also have on their website a number, an 800 number that you would call if you had questions or needed further information. And they seem to kind of have a tiered effect, so if the first tier couldn't handle it, you just kept kind of moving up the chain until you could talk to the person that was able to address that question. As far as SureScripts, and I'll say this too, is just kind of a thing that this is one reason you don't want to wait too long to get going on your project, is you have to coordinate a lot of vendors so that everybody is working together at the same time. And it was actually Imprivata that helped us with coordinating the SureScript vendor, as well as Siemens Sorian, or now Cerner Sorian. So you needed to have all those vendors working together. We had 1 week where we had everybody's attention, and this was the week that we got everything like truly done from a technology standpoint. We do go through Sorian to contact SureScripts at our facility.
Great, thank you. So as far as the process of actually prescribing is concerned, we have a question about what happens if a transmission fails and the pharmacy does not receive the order electronically.
Through Sorian and their ticketing process, our informatics team receives an email notification if their script fails. It generally comes rather quickly, usually within 30 minutes or so of the transaction being sent. Physician can also check right when they send the script. They can check to see if it was transmitted successfully, but they tend not to do that. If one does fail or we get that email notice, first step is usually calling the pharmacy, because there have been a few times that the pharmacy has said, oh no, that did come through, we received it okay. But if indeed they have not received it, then we'll either call the physician or one of the nursing staff on the unit if the physician can't come to the phone directly, and let them know that there was a script failed, that they need to take other steps to ensure that that patient gets their medication.
Great. So we have another question about whether or not you have any resident physicians who kind of rotate through the hospital, and if so, how do you manage them for EPCS?
No, we're not a big teaching facility, so we don't have residents that are working here. We have community providers that practice at our hospital. We have hospitalists. We have contracted physician groups that work here. We do have, as part of that contracted physician group, occasionally people that will rotate through that aren't always here on staff or aren't regulars or whatever. So what we do is, because they need to go through the credentialing process, and then they come to us for training, we've now incorporated some of the steps of the enrollment where they can do their identity proofing again with us. And even though they've just did it, we do it again just because we want to keep our process the same. And we can then go through the enrollment process as part of their general orientation to our Sorian software, so that they get set up that way. So that works for new physicians and for those transient ones that are maybe just going to be here for a few weeks or whatever.
Okay. Then we have another question about sort of the auditing and reporting. How often are audit reports generated? Is it daily, monthly, and sort of where do they go? Who reads them? Is that a labor-intensive process for you?
There's a couple different audit reports that are done. We have one that just looks at monthly statistics that's archived in our medical records department electronically. And we also, though, and again, this is some of the requirements, and it's probably going to vary state by state, but we have an audit report that we receive once every 24 hours, that shows us who's created. It doesn't have all the details, but it gives you the name of the physician and if they created and transmitted a prescription for a controlled substance. So our department, actually, our informatics department receives those. We look at those daily and we file them away. Physicians also have an opportunity if they want to look at their own audit as far as they can run an on-demand report that will show them what has been prescribed by them themselves so that they can review it themselves too. And we can also run an on-demand by provider if needed.
Great. So we have a couple of product-specific questions here. First one I'll ask you, Laura, and then the second one I'll take. It's about the hands-free authentication solution I mentioned. But you said that you are an Imprivata customer for single sign-on, Imprivata One Sign. Did you need to install a second Imprivata appliance or device for EPCS?
Yes, we did. We installed the Confirm ID product for the EPCS, which allows for the two-factor authentication.
Great. Okay, then we have some questions just asking to explain the hands-free authentication technology I mentioned, which I'll explain in a little more detail. So Imprivata, so hands-free authentication is an add-on capability of Imprivata Confirm ID, and it serves as something you have as one of the three factors for two-factor authentication. And essentially, it's meant to address the inconveniences of a hard or soft token, especially the hard token inconvenience that Laura had mentioned some of her providers had expressed. The provider installs Imprivata ID, which is an app on their iPhone, and that essentially serves as a soft token generator. However, the hands-free capability uses a USB receiver that sits on the endpoint, Bluetooth receiver, that can only work with Imprivata ID and cannot work with any other Bluetooth-enabled device or application. When the provider is performing EPCS, if that is enabled for the hands-free authentication piece, it will call out to their phone and automatically verify and retrieve that, or I should say retrieve and verify that token code and put it into the system, and that is your hands-free authentication factor. So if you're using that in conjunction with fingerprint scanner, for example, and you use fingerprint as the first factor, simply swipe your fingerprint, then it would automatically get the token code off the provider's phone, and you've completed the two-factor authentication. It's designed to be very fast, very secure, and convenient, and really the combination of hands-free plus fingerprint is meant to be the optimal two-factor authentication process for EPCS to make it just very seamless and convenient. I think I mentioned also that if the prescriber is using an endpoint that is not enabled with the Bluetooth receiver for hands-free, or maybe they're remote, they can still use the Imprivata ID application as a traditional soft token, and they can just manually enter it in when e-prescribing. And to answer some other questions about that, yes, it does work with multiple EMRs. We encourage you to contact us for more information. And currently, yes, hands-free authentication only works with Imprivata Confirm ID for EPCS and is not functional, available or functional as a standalone product. Okay, so I guess that is all of the questions that we have. So Laura, again, I want to thank you for your time today. We appreciate you taking the time to share your success story, and I think judging by all these questions and attendees that we have, there's definitely a lot of interest in this. So thank you very much for your time. I'm going to turn it back over to Michelle to close out.
Yeah, thanks everyone. So just a reminder, if you registered for today's session, you are going to receive a link to the on-demand recording. So if you want to listen to parts of this again, if you want to forward it on to colleagues, you are more than welcome to do that, so be on the lookout in your email for that link. I think there was one question related to a checklist. You know, is there a checklist for implementing EPCS? One thing I'd suggest, if you go to the Imprivata website, let me see if I can pull up that slide that we had here. If you go to imprivata.com/EPCS Insights, we actually have a white paper called Getting Started with EPCS, and at a high level it outlines the processes you need to think about. So that's a good starting point, I think, for people to understand what are the factors involved in the process and how do you get started. So with that, I'd like to again thank Laura for her time and for sharing her story with everyone today. You know, they are one of the first hospitals in New York to successfully implement EPCS, so congratulations to you, and thanks again to our audience for your attendance today.